Dr. DIVYA Natarajan, who is a consultant ophthalmologist specialized in children's eye care, strabismus and neuro-ophthalmology, and from LV Prasad Institute, Hyderabad. And she has another interesting set of videos, and look forward to good discussion. On to you, Divya.
Yeah, thank you, Dr. Chitra. So I'd like to thank Dr. Chitra and the committee of ARC for giving me this opportunity. Let me start. I'll be presenting three challenging cases of pediatric cataract. They are slightly different from the usual cataracts that we do. Okay. So the first one will be a case of posterior lenticchonus in a 4-month-old child. So here, after staining the capsule, I went ahead with an anterior capsulorhexis. In the first point to be remembered in a case of a posterior lenticchonus is to make an adequate sized anterior capsulorhexis, because we don't want to put too much pressure in the posterior capsule, because there's always a possibility of increasing the dehiscence that's already present. The second point is to start removing the cortex from the periphery, keeping the center intact so that you're not going to disturb the vitreous more than necessary. So at this point, I can see already there's a disturbance. So I immediately shift to the vitrector mode, go ahead with a thorough vitrectomy, removing the dehiscence that is there and making it more even. And then I try to remove whatever is the residual cortex from the periphery that is present with the vitrector in the aspiration mode itself, so that if I counter any pressure there, then immediately I just change into the vitrector mode. So once I remove the rest of the cortex from the periphery, I go ahead with an implantation of the IOL. So the IOL of choice for this case was a 3-piece IOL in the sulcus, basically because the posterior capsule was much larger in diameter. And I was not confident of placing it in the bag. So after completing it and ensuring that there was no residual vitreous there, I sutured both the wounds and the eye was securely sutured. So the take home here is that make an adequate size anterior capsulorhexis and remove the cortex from the periphery initially. The second is a 2-month-old child with a rubella cataract. There's a microcornea and there's a myotic pupil. So in this particular case, I didn't want to make too many incisions, corneal incisions, this being a microcornea. So made 2 side ports and through that inserted the iris hooks and went ahead with an anterior capsulorhexis. Visualizing the rhexis margin is the key here, and completing it, this being a very elastic capsule, always the pull should be towards the center. Completing the rhexis was the challenge here, but I was lucky I completed it. Then I went in with the vitrector and in the aspiration mode, aspirated the cortex and the nucleus, did not remove the instruments, continued the periphery cortex aspiration, changed the mode to the vitrector, went ahead with the primary posterior capsulorhexis, and then did an anterior vitrectomy without bringing the instruments out. So I think this is the key, where you don't have to have too much of instrument manipulation and not have too many corneal incisions, because that is just going to be a little difficult in a child, because sometimes in a 2-month-old child, we may have to suture even the incisions made for iris hooks. So these were the few take-homes from this particular case. The last is that of a milky white cataract with a completely liquefied cortex in a slightly older child. So here again, as we can see, as soon as I make the neck, I can see that milky white coming out. So there are different ways of decompression that we have discussed. So this is another way where I just use an irrigation in the plane of the rex. I'm not going into, there's no pressure into the lens, but then the lens intralenticular pressure is still maintained, and then I complete the rhexis with the rhexis forceps. So this almost brings out the whole liquefied cortex, and just a little bit of fibrous capsule matter that is left can be aspirated to the aspiration mode. And I just do the polishing, but those fibrous areas of the cortex are left as it is, because if we start pulling those areas, then there's a very good chance of just going right into the posterior capsule, extending of the posterior capsule and causing a large rent. So this was an IOL that was placed at the back and wound sutured. So here again, the main thing is that a slightly different way of causing the decompression for such a cataract. Thank you very much.
Very interesting videos, Divya. That was really good. I have 3 questions for you. The first case, the question is that, of course, you said that the posterior capsular excess was larger, but otherwise, could you have done a posterior optic capture in that eye is one question. Second question, I'll ask you that you answer them all together. The second case is a 2-month-old baby, so there was no question. Supposing it was a little older child, would you think it makes sense to do a manual posterior capsular excess, because that resists extension than doing a anterior vitrectomy and opening the posterior capsule? And if you are planning to place an IOL in the bag at the same instance. Now, in a 2-month-old, that was not a possibility. In the third case where you did that, do you feel that instead of using an IE all the time, sometimes some pieces are a little difficult, you need to use a phaco probe? Have you ever thought of that? And again, if you had an Argentinian flag sign, would you have done a posterior capsular excess and posteriorly captured the IOL?
Yes, thank you very much for the questions, Dr. Chitra. The first question, whether I would have done an optic capture. In many cases of pediatric cataract, I don't usually do an optic capture. However, if it's an older child, because if I go ahead with an optic capture, sometimes I see that the capsule is so elastic that it may just tear. Especially if the posterior PPC has been done with a vitrector. Yes. There's always a chance that the edge is slightly peaked over there. It's not a really even edge as we will get with a manual PPC. So, and as you said, again, in this case, it was out of the question. The second thing that you had asked was about whether in an, probably in an older child or sometimes if I may want to do a manual PPC, that's always an option. And that is something that I would probably do. Again, the only thing here was I didn't even attempt to do that because it was a 2-month-old child. Yeah. And whether have I used phaco in any child or any kind of nucleus? Yes. Sometimes in a case of a rubella cataract, the nucleus is so hard that I may just have to use the phaco probe to break it. However, what happens is that the nucleus, though it may be very hard, it will be very small in size. So actually it may just fit into that phaco probe. So what I may actually find maybe slightly suitable is make the main incision before itself and then just aspirate it. That might actually be more convenient. However, if the nucleus size is bigger, sometimes an older child presents with a rubella cataract. In that case, I just go ahead with a phaco. I've found the need to do that very less, but yes, that's possible.
In an older child, would you think of doing a posterior optic capture with this kind of intermittent cataract if you have had an Argentinian flag sign?
I have never done that, Dr. Chitra. Again, an Argentinian flag sign, even if it's an older child, the elasticity of the capsule is something that I am a little wary of.
Yeah, good. These were the important points which I wanted you to bring out in your talk.
Like the third video. Divya, the third video is very good. Yes. Wherein you did under irrigation is really fantastic.
Yes,
thank you.
Gaurav, you have anything to add to her presentation?
I think they were excellent videos, and I also like the last video because I do that myself as well. The only thing you have to be careful is that the side port should be calibrated to your instruments and should not be leaky. Otherwise, sometimes that fluttering. One thing is it will prevent fluttering of that redundant capsule as you keep tearing it, because no fluid is escaping from the side ports. And also, then you will also not have that flap come suddenly and come out of the side port. So I think very tight side ports which are calibrated to your instruments would make a lot of difference as well.